Okay. Can you guys still hear me? Sorry, I have some background noise here.
Yeah, we could.
Okay. So I'm covering a fairly broad topic. I'm Swag Mukhopadhyay. I'm one of the surgical oncologists at St. Francis Hospital and in the Yukon system. So my topics are a little bit of a hodgepodge. So head and neck, gastric, small bowel, skin soft tissue, lymphoma, and tumor biology. And I went over the score outline, which underneath those categories, there's a lot of, a fair amount of it is oncologic and tumor based, but there's a fair amount of general surgery too. So I'm going to try to just blast through all of it. So hopefully less than a minute per slide and we'll get through it. Okay, so head and neck. So I just divide it up just like how SCORE does it, so disease and conditions versus procedures. For the ABSITE, you probably won't have to worry too much about the procedures. I mean, if there's little technical things that are worth knowing, I'll try to point those out. So I have the core topics, advanced topics, but essentially one of the topics I want you to review is neck mass evaluation. So really the underlying issue is going to be where the neck mass is. So are we talking about thyroid, parathyroid, or is it what SCORE is referring to with major, minor salivary glands versus oropharyngeal, et cetera? So a thorough history and physical. Pretty much all of these patients are going to end up with either CT or MRI of the head and neck, as well as a FNA of the biopsy. Sometimes we will do an open biopsy, but usually you'll start with an FNA. If that doesn't get you a diagnosis, that's when we usually will go to an open biopsy. If you get the diagnosis, then whatever the diagnosis is, you would intervene whatever is appropriate. And then the things with any head and neck mass that you need to look out for are voice changes, airway obstructions, difficulty swallowing, sort of progressive symptoms. Those are things that you'll pick up in the stem of the question. And so that's when you really need to think about doing endoscopies like direct laryngoscopies and EGDs to assess for any sort of a larger mass than you're anticipating. So I got a lot of information from osmosis.org for any of you who use it. I've used it for a long time. I think they give great illustrations and synthesized information that you need on a general level. So anyway, so next topic, upper airway obstruction. I mean, really, you could discuss this from a oncologic standpoint, but you can also discuss this from a trauma and sort of acute issue standpoint. So really, I mean, it boils down to your ABCs initially to make sure that somebody's ideally ventilating, and if not, I mean, you're going to emergent procedures. So the different airways that you can use, oropharyngeal airway, if you're worried about some sort of trauma or some sort of blockage in the oropharynx, you can do a nasopharyngeal airway, which is actually pretty easy to put in. I mean, it's not really any harder than putting an NG tube in. And then obviously endotracheal, sometimes depending upon the scenario, if the face is completely shattered, you might have difficulty with that. So you can still go nasopharyngeal, or you might go straight to a crike. But other interventions you can do, LMAs, and knowing the medications you need for a rapid sequence intubation can be helpful, but how to crike somebody and how to do a trach, which most of you guys have done by now, and so should be able to describe reasonably. But I don't think there's really a lot more to know for upper airway obstruction. I mean, it relates to the previous slide with the evaluation of the mass and biopsies, et cetera. Next topic, which they consider an advanced topic, so you might not get too many questions out of this. These illustrations are from the Lancet, but major salivary gland, so your parotid, it's much more common to have a tumor in your parotid than your minor salivary glands, and it is more commonly benign. So most commonly it's going to be, actually that's more of the next slide, but oropharyngeal and oral cavity cancers. More often than not, these are going to be squamous cell cancers. So if you get a scenario on a question of a patient has random lymphadenopathy in their head and neck, the next step, if after history and physical, et cetera, is going to be usually getting an FNA biopsy of it. And it's going to tell you that it comes back with squamous cell. And then usually it'll ask you what is the most common source or where is that likely originating. And it's going to be in the tonsillar pillars. So that's the most common site of a unknown primary for head and neck. And the workup for that, you do your endoscopies, you do your evaluation. For squamous cell, you're eventually going to work your way potentially to a PET scan. Squamous cells light up very well on PET scan. So if you guys have had any experience in the head and neck, you'll know that they order a lot of PET CTs. The things to look out for, again, are the same things that we talked about for the neck mass. Then the thing that I was kind of skipped forward to, so as far as salivary gland tumors, so you've got your major and minor salivary glands. So you've got your parotid, then submandibular is the next kind of smaller down, then sublingual. I mean, you have 500 to 1,000 small salivary glands throughout your oropharynx. So really problems can arise from any of them. The parotid, the vast majority of the time, tumors in the parotid are benign. The minor salivary glands, it flips. The minor salivary gland tumors are more likely to be malignant. So, in terms of benign versus malignant, the most common benign is going to be a pleomorphic adenoma, or next would be a Warthin's tumor, versus malignant, most common would be a mucoepidermal carcinoma or adenoid cystic carcinoma. More than likely, they're not going to ask you guys beyond that. I mean, you're not taking an ENT or exam, so really that should be kind of where it ends. And the answer for anything in the major glands and minor glands is essentially excision. And then if you excise it, if you have positive margins or if they're close margins, it is a very low threshold to do radiation therapy. So most things in the head and neck respond very, very, very well to chemoradiation. And so whether you're talking about squamous cell or whether you're talking about any of the tumors that I just mentioned, because, so first line, ideally you cut it out and then potentially adjuvant radiotherapy, depending upon, if they give you what sounds like close margins or positive margins. In the setting of recurrence, again, you can do surgery, but you should consider whether chemoradiotherapy is a reasonable option. Okay, so within head and neck, the operations and procedures that they want you guys to know. So one of the core ones is a lymph node biopsy. So I'm sure that all of you guys have seen diagrams like this with the different nodal stations of the neck and the different triangles of the neck, etc. I don't know if they'll be as nitpicky as to ask you what specific nodal level is being dissected, like if they give you the borders. I mean, that might be a little too detailed. The main thing that they might ask is like, so, your level 6 here, where the yellow is highlighted. So that's your level 6, that's your central compartment. So that's where, if you've got medullary thyroid cancer or a papillary thyroid cancer where there is some nodal involvement in a different area, that's where you're going to do primarily your nodal dissection and then any other involved areas. With medullary, I mean, you're gonna be more aggressive, but the nodal section, so level 6 is that central compartment. Your submental nodes are your 1A, 1B, that's divided by the anterior belly of a digastric. 2A, 2B are kind of high up, but just inferior to the parotid, and then level 3, level 4, and then are, those are all along the sternocleidomastoid. And then level 5 is your posterior triangle. And usually for most of the stuff that we're doing as general surgery, you're not going to get into a level 5 node, but it's still, those are the main ones that they're going to ask you about. I don't think you're going to need to end up knowing the ones in like the buccal areas and, up higher, like near the occiput and stuff like that. Because, I mean, it goes all the way up to 13. And I think as long as you generally know the borders and the divisions for 1 through 6, you're going to be fine. The one thing to know about here, which is, I can show you on the modified neck dissection. So, is Erb's point, which is the sort of nerve center of the neck, essentially. So if you look at along the posterior border of the sternocleidomastoid, where all of these nerves are coming out, that's the eponym for it is Erb's point. So usually most people will define it. This diagram is a little bit off actually, because it's usually the where the crossing of the external jugular that you see the vein anteriorly, where that external jugular crosses the sternocleidomastoid. If you go up approximately 1 centimeter on the sternocleidomastoid from there, that's Erb's point. And if you go up about 1 centimeter from there, that's where the spinal accessory nerve will come out. And so in the setting of a lymph node biopsy, etc., that's going to be really the main nerve that you're looking out for. Your brachial plexus, etc., they're going to be protected by the scalene. So if you're staying just behind the SCM, along the carotid sheath, etc., as long as you're not getting the vagus, and as long as you're staying careful for the spinal accessory, really most other nerves are not free game, but they're not going to have quite as much morbidity associated with it. And so now specifically for this slide, they want you guys to know what a modified neck dissection is. So radical neck dissection would be when somebody takes the jugular, the carotid, the SCM, and the spinal accessory, right? So when you are preserving any one of those structures, it's automatically a modified neck dissection. In modern day, we do very few, I've never seen a radical neck dissection, but generally speaking, you spare the spinal accessory, and then depending upon what the underlying pathology is, what's involved, you could take some of these other structures, but again, usually we lean away from taking these structures now. Then parotidectomy, another one that they consider an advanced topic. So there are superficial and deep parotidectomies. So the reason that the parotid's important, in case you guys, if it's buried back there somewhere, is because your facial nerve is going to come in front of your styloid process, and it's going to come out right here in front of your tragus, and it's going to basically go into its 5 branches. And so, and those branches are going to divide the superficial and the deep parotid. And so almost any time that we do a parotidectomy, we're doing a superficial parotidectomy. So for me, in terms of head and neck, I do melanoma. So if there's a melanoma on the head or neck, there's a pretty decent chance that if they need a sentinel node biopsy, which most head and neck melanomas do, that the most likely place for it to track to is going to be the parotid. So if you do head and neck melanomas, you have to be at least somewhat comfortable doing a parotidectomy. So usually you make a facelift incision, actually kind of cut out how it is. You make a sharp angle right at the earlobe and come down. Some people will come all the way down and around the jaw. I usually will come along with an anterior sternocleidomastoid incision as well, and then you basically, get into your subplatysmal plane, peel up. The landmark, I was actually tested on this in the ABSITE once. The landmark that you can use to ensure that you're not getting to the facial nerve and causing damage is actually the posterior belly of the digastric, because that will run from here, from the styloid process. I don't know if you guys can see my cursor, but behind the ear, essentially, it'll come down to the hyoid and then it comes up to the jaw. But that posterior belly, the facial nerve comes out from that, behind that styloid process, deep to that posterior belly. So if you can see that muscle, it's not unheard of to have an injury, but you're at much lower likelihood of having an injury. Trying to think what else they could ask you guys about parotids. Really, if they're asking you about a parotidectomy on a general surgery exam, it's going to be likely related to a melanoma, and it's going to be, you did a sentinel node biopsy. They might give you a picture of like a lymphoscintigraphy, so like a nuclear medicine study where they're showing the flow of the tracer, and it looks like it's all on the front of the face. So if they ask you what the next step is, it's going to be a superficial parotidectomy. Okay, so whirlwind of head and neck. I know we have a lot of stuff to cover, so if there's any questions, feel free to reach out to me. If we do have some time at the end, I'm happy to take anything, but I'll probably wait until the end. So stomach, again, disease and conditions. So pretty much everything in the stomach they consider essentially a core topic, except for some of the advanced procedures. So functional gastric disorders. So the main things that people think about, and I have patients who deal with this because they might end up needing gastrectomies, et cetera. So gastroparesis versus dumping syndrome. And then if you're familiar with dumping syndrome, there's early dumping versus late dumping. So gastroparesis, kind of, you can figure it out from the word itself, but essentially poor function of the stomach. So typically it's diagnosed based off of clinical symptoms. You can do a gastric emptying study, which is again a nuclear medicine study that looks at how quickly the stomach is emptying. And depending upon what you find and what portion of the stomach appears to be squeezing inappropriately, you can use different medications to affect change. So the most common one I'm sure all of you guys have used is Reglan. The vast majority of the time that by itself will be effective. There are newer medications that people have come out with. Erythromycin is a tried and true, that's the one that people used to use. But the problem with erythromycin is that it actually increases intestinal motility, but sometimes it can actually decrease, in a paradoxical fashion, it can actually decrease your gastric emptying. So you have to be careful about it. And if medications don't work, you can essentially do a distal sphincterotomy, so a pyloroplasty. You can do if you guys know what an endoflip is, where you test the distensibility using endoscopic means. You can essentially do a stretching of the pylorus and stretching of the area that you're worried about, and assist with emptying. Or you can do a gastric poem, and like I said, you can do a surgical pyloroplasty. Dumping syndrome, usually that's in a post-surgical setting. So the vast majority of the time, the causes early versus late. Early is because of the hyperosmolar load. The late dumping is because that hyperosmolar load may cause issues with insulin sensitivity. So that high level of insulin release with that high osmotic load. So one happens within usually 30 minutes of eating. The other one is usually within 1 to 3 hours of eating. So that, but at the end of the day, the management of them is very similar in terms of changing food to be more protein-based, high fiber, lower carb meals, small meals multiple times throughout the day. There are medications you can use that, to decrease the motility, almost the opposite of a gastroparesis to slow things down. You can use octreotide to decrease secretions because those are responsible for a lot of the issues. And ultimately, if things aren't getting better, depending upon what the underlying issue was that if it's from a bariatric surgery, you could consider reversing them or reconstructing them in a way that helps them. Usually if it's for a malignancy, you're pretty hard pressed to have a way to reconstruct them if they're having dumping syndrome. It's really medication and lifestyle modifications. Okay, gastric cancer, these are topics we could easily spend a long time on. So some of the major genetic mutations associated with gastric cancer. So with the APC mutation, so FAP, obviously important for colon cancer as well. Many of these patients end up with gastric cancers, with duodenal cancers. They may end up with combined gastrectomies, Whipples, etc. And especially if you have a question where it's a patient who has FAP and that's a known thing, they need an upper endoscopy prior to any surgery because you need to know where all the polyps could possibly be. Because if they have like a Y mutation where it's like an attenuated version of FAP, then you may be able to just do one resection versus needing to do a pretty massive resection. The other one to really, obviously Lynch syndrome, all these things, I mean, they are important with one of the important ones that has been tested a lot recently for gastric is the CDH1, because that has a relationship with breast cancer as well. But it's because those patients require total gastrectomy fairly early in age. Depending upon where you read, the guidelines will say 25 years of age. Some places will say 40, but most people will do their total gastrectomies early. And so anytime you have a situation like that where you're doing something what seems pretty aggressive, that's fodder for test questions. Then from the European guidelines, just the basic staging for gastric cancer. So usually you'll have somebody comes in with bleeding or unanticipated weight loss, something along those lines. They'll end up with endoscopies and, you'll biopsy it, comes back as a gastric cancer. You want to know their PDL status and their HER2 status if you get questions about that. I think that's getting more into fellowship level. But you want, any cancer, I'm sure you guys have heard this from any surgeons you've worked with who deal with cancer, anybody who deals with cancer, you name it, you stage it, and you treat it. So your biopsies, et cetera, are going to name it, then you stage it with your CT, so CT of the chest, side, and pelvis. If it appears to be early stage, something that is small enough or early enough that is amenable to endoscopic resection, you want to do an EUS, because that will give you your T staging. I didn't put all of the staging stuff on here, but the T staging in terms of how far into the wall of the stomach has it gone. Because if it's a early T1, small size, well-differentiated tumor, you can do a endoscopic resection and have them under surveillance without doing much else. If it's a more advanced tumor, like if you're starting to see local adenopathy, or you do your EUS and it looks like it's a T3 or greater, then most people feel that a diagnostic laparoscopy and washings is pretty mandatory, because even with T3, what was seen as T3 cancers on EUS, I've seen on diagnostic laparoscopy patients with positive findings, and positive cytology for malignant cells. And those patients, there was you don't need to know this, but just for background information, there was a Dutch study that showed that after 3 years, essentially survival was 0 for that subset of patients, regardless of therapy or surgical intervention. So it's one of those things where, it's important to know because it gives you it gives you a better idea of prognosis. PET, we very rarely use in the stomach, in the setting of stomach cancer. If you think it's resectable, if it's not obvious, a lot of times PET can be misleading, because gastric cancers tend not to be PET avid. So I've had patients who come in who needed a gastrectomy, but then the PET was negative for any activity, but they had a positive biopsy and they refused resection, and any other treatment because they just could not grasp the concept of a PET and whatnot. So it can be pretty frustrating. So you have to be very careful if you're talking about a PET for gastric cancer. Esophageal cancer or gastroesophageal cancer, much more common to use a PET scan, and that is standard part of staging for those. Gastric, it is not a standard part of staging, and so that they'll use that sometimes to confuse you guys, so that's why it's important to know that. All right, so if it's localized, that's where we get involved. Metastatic gastric cancer, like I said, is not really an area that surgery has much role. So on the right corner, I just put the sort of immunohistochemistry and markers that, if they ask you about that, these are reasonable to order. So the HER2, PD-L1, Lynch syndrome markers essentially. So, and the Claudin 18.2. If it's localized, like I said, if it's very early, well differentiated, small, so less than 2 centimeters, then you can do an endoscopic resection. Anything else, all the way up to metastatic disease, you are likely going to start with this column where it's preoperative chemotherapy. Then you're going to, for about 2 months or so, you're going to do your resection, and then you're going to follow up with the remainder of your chemotherapy. Every once in a while, there's no preoperative chemotherapy given. If somebody shows up with bleeding or some other issue or gastric outlet obstruction, et cetera, those are the settings where you might do a radical gastrectomy and then do all of their chemotherapy after the fact. Okay, foreign bodies. I'm sure you covered this a little bit in pediatric surgery. The main thing we worry about, disc batteries, those are usually stuck in the esophagus, and the questions you guys will get, and you have to go after those. Or if you can't tell what it is, and it could be in the stomach. This is from the current endoscopic, like GI endoscopy guidelines. So, if it's sharp and long and you don't think it's going to go through any of the sphincters that it needs to go through, or it's going to get stuck, then you need to try to go get it out. If it's sharp and small or narrow or blunt, if it's sharp, it needs to be very small. Otherwise, if it's blunt and narrow, then you can basically watch it. And if it's metallic, you follow its serial x-rays. If it's non-metallic, then, like if it's a glass, etc., then you just wait for it to pass. But I'm sure many of the settings that you guys work in, similar to UConn, like, the patients will swallow things, etc. And so even though these are the guidelines, you might see different things. But with foreign body ingestion, again, it just boils down to, do you think it's going to get stuck? Do you think it's going to cause a perforation? If not, then 4 weeks is a reasonable amount of time to give somebody before you try to do anything else. And if they're clinically stable and they're not having any issues, then, many people I've seen watch for an even longer period of time. So back to stuff that's more near and dear to my heart. So malignancies. So GIST, specifically gastric GISTs, and then they said in their topics, they said miscellaneous digestive neoplasms. So GIST is something they love to test you guys on. So GISTs are more on the sarcoma spectrum. So GISTs typically, if they're going to metastasize, they will go to the liver and the lungs, more like a bloodborne thing, but it is very, very, very low likelihood that GIST will metastasize. So only the really big aggressive ones, the really poorly differentiated ones do, or like the high grade ones. So typically for GIST, you'll have somebody who shows up with bleeding or something seen on a CT scan. If you can get the bleeding controlled, then you do the typical cancer workup. If you can't get it controlled, you manage it like an upper GI bleed. So if it's going down the cancer workup, then usually you will do an endoscopic ultrasound, because it will usually say it's a submucosal mass. Other gastric cancers tend to be mucosal masses. So it'll be a submucosal mass on endoscopic ultrasound. It's coming from the muscularis. You get a biopsy of it. There's a host of different mutations that you should test for and different immunohistochemistries, but the main one to know is the c-KIT. So that KIT mutation is present in about 75%. The other one that is fairly common is the PDGFRA. But between those two, you're going to get the majority of GISTs. And then subsequent to that, most of these patients, you don't need to get a CT chest as long as you've got an abdomen pelvis. It's less than 5 centimeters. You don't need to worry about doing a lot of other things. If it's greater than 5 centimeters, you should get a CT chest. You should look at their liver, etc. And then based upon its characteristics, you can decide whether it makes sense to do neoadjuvant imatinib or surgery and then adjuvant imatinib. So exon 11 is the most common mutation for GISTs. That one you can treat with an imatinib. And your decision to use imatinib or not is going to be whether it's near an area that you feel comfortable resecting. So if it's near the GE junction, if it's really big and you're going to have to do a total gastrectomy, if it's right by the pylorus, you might consider doing imatinib or Gleevec first and see if you can shrink it down. And imatinib will actually have some positive effect on bleeding too. So you can shrink it down, then do the resection. Or if it's amenable to resection up front, resect it, and then based upon the tumor biology and size, that will give you an idea of whether it's a high-risk GIST or if it's a low-risk GIST. And if it's a low-risk GIST, you don't usually have to do Gleevec, but any moderate to high-risk GIST, so anything that's 5 centimeters or larger or has a high mitotic rate or is a high grade, those patients usually need, people used to say 3 years. Now some people are saying 5 years, but I would say minimum 3 years of adjuvant Gleevec therapy, because there's data out there that it doesn't really matter after 3 years, that the outcomes start to kind of come together. But so you should do 3 years of adjuvant therapy. Oh, one thing is, and I did get asked about this on a prior ABSITE. So if they have an exon 9 mutation, then you need to use double imatinib because it's resistant. Okay, peptic ulcer disease. You guys, I'm sure, know this classification. So 1 through 5. So 1 is one type, one location. 2, you've got the so along the gastric body, lesser curve. 2, body of stomach and duodenal. 3, right in the prepyloric area. 4, high up on the lesser curve. And then 5, usually associated with NSAID use. Types 2 and 3 are the ones associated with acid for secretion. One of the things that you need to know for any of these patients is their H. pylori status. And actually, sorry, one thing going back for GIST, for miscellaneous gastric neoplasms, one thing is maltomas. Okay, so mucosal associated lymphatic tissue. So you can get tumors there from H. pylori infections. So if you treat their H. pylori, the vast majority of the time, their cancer will also disappear. And so you do need to know the different, triple, quadruple therapy, testing for H. pylori. So if somebody does have a perforation, getting a biopsy, not just for cancer, but also getting a biopsy for H. pylori testing. And then if somebody has been treated for H. pylori and they still come in with a perforation, that's the setting where one of the topics they actually want you guys to know about doing vagotomies and drainage procedures is important. They consider stress gastritis a core topic. Anybody who spent any time on ICU rotation knows about stress gastritis. Essentially, you manage the symptoms while you are trying to fix the underlying problem. And multiple things, including H. pylori, can cause it. Most commonly, again, it's going to be in the ICU setting. Somebody who's had an NG tube in for a long time, is not getting fed enterally, is very, very sick, that type of situation. And again, you use intermittent PPIs, et cetera, but the main thing is to fix the underlying problem. Again, within the topics given to me, upper GI bleeding, so we could spend a lot of time on this. Anything that can cause erosion or holes in your upper GI tract, so from your stomach all the way down to the end of ligament of Treitz, so to the end of your duodenum. So Mallory-Weiss tears, ulcerative disease, etc., tumors, pancreatic tumors that are eroding in, gastrinomas, etc. Those are things you need to worry about. Cirrhosis, etc., that can cause an upper GI bleed. And then here they have blood disorders listed. Again, I don't know that you guys are going to get tested on that, but any sort of bleeding, you localize, right? It is very rare in this modern day and age for us not to be able to localize bleeding if you try long enough, So the first thing is localize, localize, localize. Your options are your endoscopies and CTA. You can do a targeted angiogram if you think you know where it's coming from. A tagged red blood cell scan can be helpful if you have no clue where it's coming from, but that's just going to give you essentially a quadrant that the bleeding is likely occurring in, but it's not going to give you an organ system. So that can sometimes, be less than helpful. And then obviously, depending upon the level of the bleed, you start with PPIs, if they're anticoagulated, you either hold their anticoagulation or you reverse them. And then the reason we like endoscopies is because they can be diagnostic as well as therapeutic. And then ultimately, surgery if there's no other options. And for an upper GI bleed where you're doing a surgery, it's either going to be a gastric or duodenal issue. So in the setting of a gastric thing, so gastric bleeds, especially if it's from a tumor, are much more likely to be malignant than a duodenal issue. So those you have to try to biopsy. But, in that setting, you would make an anterior gastrotomy, find the bleeding, oversew it, put whatever thrombotic agents that you want to onto it and leave an NG tube, etc. Usually you want to put some sort of feeding access past it. So if you want to pass a Daboff tube, etc., past it, you can, and then close up. If it's a duodenal, then you do a longitudinal duodenotomy. You'll see the bleeding. You have to get there's usually a vessel that looks like a T going through it. So you have to get the bleeding at the top, the bottom, and medially. You tie those off, control your bleeding. If it looks really concerning, you can get a biopsy of it, but no one's going to fault you if you don't get a biopsy of that. And then you close your duodenotomy that you made longitudinally. You close that in a transverse fashion, and go from there. Okay, so operations procedures. So they want you guys to know access procedures for nutritional support. So, you can use an NG tube, feed gastric. The surgical version of that is going to be a gastrostomy tube. So anybody, again, who's been in the ICU or been on peds has probably seen these. You can do, they say nasoduodenal, but really, nasoduodenal, nasojejunal, but basically something that's going to go past the pylorus and provide post-pyloric feeding. And then you can do a jejunostomy tube. Of course, you can also do a gastrostomy tube that you convert over to a jejunostomy tube, or a GJ tube. So those are all the different ways that you're feeding somebody. And really the question is it post-pyloric or not? Because that's going to decide whether you can do bolus feeds versus continuous feeds, et cetera, because the intestines are more used to continuous feeding. Stomach handles bolus feeding a little bit better. So that can decide what type of feeding access you might be placing. And of course, if you've got a tumor or something causing a blockage, that can also decide what type of feeding access you're going to be putting in. They want you guys to know about gastrectomies. So there is such a thing as a proximal gastrectomy. Not many of the hospitals around here do it, but you can do a proximal gastrectomy with a double barrel reconstruction. I don't think you'll need to know that for the ABSITE. The ones you guys will need to know is a distal gastrectomy, where you're taking out essentially the antrum. Then between C and D, you've got your subtotal gastrectomy, and then a total gastrectomy. Subtotal is usually when you're taking more than about 70%, but not doing a total gastrectomy. And then your lymph node stations along the lesser curve, you've got stations 1, 3, 5. Along the greater curve, you've got 2, 4, 6. That is your D1 resection, when you basically get the lymph nodes that are just along the left and right gastric, and then along the gastroepiploic. The D2 is when you're basically taking down everything along the celiac axis. And so, people, I'm sure you guys have heard where people will debate about D1 versus D2 in Japan. They do D2s here. Many people do D1s. I routinely do D2, but it's one of those things where the US data just isn't quite there yet. They want you guys to know how to fix perforations in the duodenum. So, we call everything a gram patch, but there are actually different ways. So if you can just suture it, a Kellen-Jones is where so that's actually what most of us do. Most of us don't actually do a gram patch. So the Jones technique is where you have the pedicled omental flap that you're bringing up and you're laying it down in the hole, and then you're tying the sutures down over it. A true gram patch is actually a free omental flap. So you're just taking a section of the omentum, like a big hunk of omentum, totally separately, and you're just shoving it in, and then you're tying your sutures down over it. So then you have some different, this is more trauma, but in terms of perforations, et cetera, over the duodenum, there's a classification for it. And then your goal is to basically buttress it as much as possible. If it's not a big deal, if it's just a tiny little thing, then you can just close it up. Once you start getting to 50% or greater circumference, especially when you're involving D2, that's where you need to be really careful. If you're on the medial wall, like right where the pancreas is coming in near the ampulla, versus on the antimesenteric wall, then you have a few more options. You can do things like duodenostomy tubes. You can do Roux-en-Y reconstructions. You can do bowel patches where you bring up a loop of, you close it, you bring up a loop of jejunum, and then you do interrupted stitches all the way around to create a flap. Worst case, you can exclude the area, so you can bring up a loop gastrojejunostomy and then exclude the pylorus after you do your closure if you're really worried about it. Make sure you put in feeding access at the time as well, and drainage, like drains around your repair so that if it leaks, there's a way for it to flow out. And then worst case scenario, you have to do a Whipple. If you're considering doing a Whipple, which I have had to do a couple of times, but you really need to consider whether you're making the right decision. Like, you really need to consider whether one of these other options might be a better option. Okay. Then they consider vagotomy and drainage a core topic, which honestly is pretty crazy because there's only a couple of us that will still probably do these, depending upon the setting. So the types of vagotomy, so you can get a truncal vagotomy, so you need to be approximately 6 centimeters up on the esophagus, and you need to take out a 1 centimeter chunk of the anterior and posterior vagus, and you need to send it to pathology to verify that it is in fact nerve tissue, because there can be a lot of stuff that looks like nerves that are not nerves. So that's if you want to take out the entire innervation to the stomach. If you do that, then as you can imagine, the stomach's not going to squeeze very well, and it's not going to empty very well. So people will usually do a pyloroplasty at the time. So they'll open it longitudinally right over the pylorus, and then they'll close it. So that's this Heineke-Mikulitz pyloroplasty. You've got your selective versus highly selective versions as well. So the selective, as you can see from the diagram, you're leaving the innervation to the pylorus, and you're going a little bit further down from the trunk. Whereas the highly selective, you're dividing right where the antrum is, essentially. So where not where your antrum is, but a little bit more proximally, where your acid secreting cells are going to be getting their innervation, because the entire goal of a vagotomy is to decrease your acid production. Now, in terms of ways to reconstruct, there's the gastrojejunostomy, like I talked about. You bring up your loop of jejunum and sew it to your stomach. Heineke-Mikulitz, which is probably the most common. You've got your Finney, where if you've got a big hole or issue here near your pylorus and your duodenum, you can basically open it up longitudinally and then do a hand sewn essentially side to side anastomosis. And then a jaboulet is when, the reason that it shows the 2 incisions, proximally and distally, is because this whole intervening section is essentially messed up or hardened, or there's some sort of problem. So you're bringing the stomach up to the duodenum, the duodenum up to the stomach, and you're creating anastomosis, but not bringing up the jejunum. Okay. They want you guys to know procedure for morbid obesity. I will let you do that on your own. Just, we don't really do gastric bands anymore, but I'm not a bariatric surgeon, so I'm sure that at least a couple of bariatric surgeons that you can talk to about these. But in terms of revisional procedures after gastrectomy, most common bariatric procedures. So I do see a fair number of these patients. So after they've had a bariatric procedure, they're having issues. And most commonly, you're switching them from a gastric sleeve over to a Roux-en-Y. Now, you can do a duodenal switch, etc. But again, that part I would talk to about with the bariatric surgeon. Okay. We only got 10-ish minutes left, so I'll try to fly a little bit. Small bowel. Acute mesenteric ischemia, so many different causes, but to boil it down to, you can have there's obviously chronic mesenteric ischemia from congestion. That's a separate thing, but the 3 that are going to cause truly acute are going to be your thrombotic or embolic arterial issues. You've got mesenteric venous thrombosis, or you've got NOMI, so non-occlusive mesenteric ischemia. All of these are managed slightly differently. With embolic, you're going to have that jejunal sparing because the embolism goes down the SMA typically, and it's that first part that the SMA is giving flow to, the first part of the jejunum, that's going to be spared, versus thrombotic, that's usually going to be the entire jejunum looks affected. Mesenteric venous thrombosis and non-occlusive mesenteric ischemia, mesenteric venous thrombosis usually is going to be managed with anticoagulation as opposed to embolectomy, etc., or angioplasty. And then NOMI, where it's non-occlusive, usually this is a low flow state, so that's going to be managed with essentially ICU support and anticoagulation, etc., and fixing the underlying problem, as opposed to having to go take out an embolus, etc. Intracutaneous fistula, again, big topic. What it boils down to is your goals have to be to control spillage, to quantify spillage, and to provide nutritional support. So your goal, so low output versus high output, usually most people will use this less than 200 over 24 hours versus over 500. But even if it's over 500 over 24 hours, there are people who will use 1.5 or 2 liters as their upper limit, because your goal is, if you've got a high output fistula from whatever underlying process, malignancy, post-operatively, whatever the case might be, your goal is to turn a high output fistula into low output fistula with appropriate wound care and nutrition. And most fistula actually close without needing any operative intervention. And most high output fistulas can actually be converted to a low output fistula if you provide the appropriate support. But if it's not possible, you want to give enough time to be able to go in safely. So you want to know what the, you have to plan for adhesiolysis, residual bowel length, etc. So, it's one of those things where you kind of push these down the road as much as you can, very intentionally, as opposed to in an avoidant manner. Okay, Meckel's diverticulum, you guys probably all know the rule of twos by this point. You can have gastric mucosa or pancreatic mucosa. If it's causing symptoms, then, that's the situation where you resect it. If it's not causing any symptoms, unless you are operating on them for a reason that could be confusing in the future, then you could consider resecting it. But usually if it's incidentally found, you just leave it alone. Ileus is one of the topics. Again, whatever the underlying issue for the ileus is, that's what you want to fix. Typically, we're not operating on ileus, right? We're operating on bowel obstructions from a different problem, but not a paralytic ileus. Radiation enteritis, a little bit more of my day-to-day stuff. Radiation enteritis, people get it from, any sort of radiation therapy to the abdomen or to the back, because some of these fields can be broader than we want them to be. Sometimes there's background radiation that happens, etc. But essentially, the patients end up with hardened, non-functional intestines that aren't able to absorb. So you need to slow down their motility. You need to give them nutritional support because they have a lot of vitamin deficiencies. You can do hyperbaric oxygen. There has been some trials that show benefit to that. But, at times you may need to operate on them if they're having significant symptoms and if they're having obstructions, etc. from it. And worst case scenario, you have to consider a bowel transplant. Small intestinal neoplasms. So again, there's a bunch of them. Obviously, there's benign as well as malignant. I focused a little bit more on the malignant ones. Adenocarcinoma versus lymphoma, carcinoid, and GIST. So adenocarcinoma, the main thing is, like with any cancer, naming it can be very difficult because unless they came in with a bowel obstruction, you resected it, and then the pathology showed you that it was a small bowel adenocarcinoma, there's not a good way to biopsy these. Usually you're going to act based upon imaging findings. So naming it is difficult, but part of it is you're going to get a CEA just like you would for colon cancer. You're going to get imaging, so CT abdomen, pelvis, CT chest. You can get a CT or MR enterography to try to see this mass, especially if they're bleeding, et cetera, from it, which is the most common thing. Then, you have to go in and resect it. And then you follow them just like you would a colon cancer patient. And these patients need to be worked up for FAP and other familial issues. Lymphomas, typically we don't manage lymphomas surgically. This is one of the few situations where if it's a small bowel lymphoma, many times these patients will show up with obstructions and you can't really get them started on steroids or on different therapies that might help them. So you just have to fix the obstruction. So you just basically go resect the area. You do take some nodes, but it kind of, your nodal harvest doesn't matter quite as much because if it's an underlying lymphoma, but you still do a cancer surgery. Carcinoid, typically, again, you try to name it. There are usually characteristic findings within the mesentery where there's a very infiltrative looking mass. Whether or not you can resect these versus just bypass them and do a palliative procedure is dependent on how much the mesentery is actually involved. If it's very central, you can't really cut those out. So for these patients, again, you try to name it. Along with that, you get a urinary 5-HIAA and a chromogranin levels. You look for liver mets because those are very common. You can get what's called a dotatate or a 68 gallium PET scan. That shows these neuroendocrine tumors very well. And then GIST, again, stomach is the most common. Small bowel, pretty much anybody with a small bowel GIST or aberrant GIST in a different location should get imatinib. But either way, so and then finally metastases, the things that can metastasize to small bowel, lung cancer, melanoma, breast cancer. Out of those three, the most common metastasis to small bowel is melanoma. Small bowel obstruction, I'm going to assume you guys know how to manage small bowel obstructions. Again, just depends on how sick the patient is, whether or not you think you can watch them, whether or not you think they need to go to the operating room, whether or not you think they need a gastrographin challenge, etc. But this, just look at the stem of the question and that will guide you towards what the appropriate management is. Blind loop syndrome. So this is, after you do any sort of intestinal reconstruction, if you have something that's not draining well. Blind loop syndrome really should be called bacterial overgrowth syndrome because it's primarily related to stuff getting built up, the bacteria overgrows, and then patients have symptoms from it, all the way up to perforating. So really the main thing is appropriate antibiotic therapy, figuring out, initially being conservative, see if you can get that blind loop to actually decompress. If not, if it's high up, sometimes you can do it endoscopically, but sometimes you have to go and surgically revise the problem. Okay, shortcut. So when you don't have enough small bowel or colon essentially to absorb what you're taking in. So on the right side, you can see, if you've still got colon, you can tolerate having a lot less bowel. They're saying down to 30 centimeters. I think most people would disagree with that. That is a very, very small amount of small bowel. The lowest I've usually seen is 50 to 100 centimeters if you've got a patent ileocecal valve. If you don't, or if your ileocecal valve has been resected and you're primarily relying on small bowel and a small bowel colonic anastomosis, then you're going to need usually about, most people I think would say about 150. So I would say these numbers are a little on the lower side. Adhesiolysis, self-explanatory. Ileostomy, so looking at ileostomy outputs, etc., and deciding when to close. One of the questions that routinely pops up is workup before you close somebody for an ileostomy, before you close somebody's ileostomy. So, usually you want to make sure whatever their underlying problem was that led to them having an ileostomy is now better. So whether they need a colonoscopy or a barium enema, etc., but making sure that their distal intestines are still working. Crohn's procedures. So, you know, most of the time we try not to operate on Crohn's. The only times is when they start getting fistulas or perforating, or they have the fistulizing version internally that are causing a blind loop syndrome. Those are the situations where sometimes we will get involved. Obviously, ulcerative colitis is a lot more common for us to operate on.
I think
Okay.
it's 12:20.
Okay, I can stop, but I can just share my slides, but you know, whatever you guys want me to do.
If you can send me your slides, I will share to the rest of the residents. But thank you so much for your time, Dr. M. We have Dr. Vargas Pinto here to continue the endocrine surgery section.
Okay, perfect. All right, thank you guys. Good luck.
Thank you. Have a good day.